today's case study, carrying on our CNS theme. Now, today's case study revolves around nerve pain, also known as neuropathic pain, and its treatment. So let's start. So the question reads, one of your regular diabetic patients, 54-year-old Mrs. Payne, enters the pharmacy. She complains of numbness and tingling in her hands, which has come out of nowhere. At first it wasn't that bad, however now she has developed a burning pain in her hands. She's also been getting gas since taking her tablets on an empty stomach, but finds it helps with routine since she takes her medication when she first gets up in the morning now. As a result, she went to see her GP, who gave her a painkiller and told her to buy a product called Simethicone from the pharmacy for gas. Dr. Locum also prescribed some of her regular medication since she was running a bit low. Mrs. Payne hands you the following prescription. She tells you the pain medication is the most important and doesn't mind coming back for the rest tomorrow if you don't have them in stock. Identify the 2 drug therapy problems present. Now, screening the prescription, our first drug therapy problem is to do with how the patient's pain is being treated. Now, neuropathies, i.e. nerve pain, may affect up to 50% of diabetic patients. Now, chronic painful neuropathy is the most common type of neuropathy, affecting up to 26% of diabetics. Now, different types of nerves may be affected in peripheral neuropathy, so that are, affecting the peripheries, and that can include sensory nerves, and sensory nerves being those responsible for transmitting sensations such as pain or touch and so on. You've got motor nerves. So motor nerves, being those responsible for controlling, say, muscles, because they're involved in, movement, such forth. And autonomic nerves. Autonomic nerves being those responsible for regulating automatic functions of the body, such as blood pressure or bladder function. Now, common symptoms of peripheral neuropathy may include numbness and tingling, so that's being experienced by a patient, and that includes especially in the extremities like the hands or the feet, as well as burning or a shooting or stabbing pain, and a burning pain is being experienced by a patient. Now, this means, it's most likely that our patient is suffering from nerve pain or neuropathic pain. Just note that you can even get, loss of balance or coordination because it can affect different nerves, neuropathic pain, peripheral neuropathy, sorry. Now, to understand which pain medications may be used to treat nerve pain, to be able to assess whether this is appropriate, we need to look at some pharmacology, specifically the descending inhibitory pathway, which is involved in, interfering with pain transmission and interferes with another pathway we need to be aware of, and that's the ascending pain pathway. Now, the ascending pain pathway is just how pain is transmitted from, the area up to the brain and processed. And we're just going to go do a quick run through, and this is just a zoom out. So say we have some sort of noxious stimuli like a nail being put into someone's finger. Now, this noxious stimuli can activate pain receptors known as nociceptors, and this can cause the release of pain-inducing chemicals. So pain-inducing chemicals can include those such as substance P or bradykinin or some sort of pain-inducing chemical. And what this does is it causes transmission of signals via sensory neurons, or a sensory neuron and sensory through a sensory nerve, through the dorsal root into grey matter. And this is, just imagine this is a cross section of, say, the spine. If you chopped it and we looked at a 45-degree angle. Now, so this primary neuron transmits the signal through the dorsal root into the grey matter, where an interneuron, so it's then transferred to an interneuron, so from electrical to chemical, then back to electrical, and it's sent up through the spinothalamic tract, so from the spine up to the thalamus. And remember, the thalamus is the relay center of the brain, so it's going to send the signal to the appropriate areas of the brain, and then it's going to be processed as pain. Now, that is just a very basic look at the ascending pain pathway. Now, remember that when we're looking at that descending inhibitory pain pathway, which interferes with this pathway, we need to look at the brainstem. Now, the brainstem is made up of the midbrain, the pons, and the medulla oblongata. Now, if we grasp an understanding and zoom in closer, we can get a better idea of what this is going to involve. So we're going to look specifically at branches coming up from the midbrain and the pons. And what happens is the midbrain branches to what's known as the periaqueductal grey, and the pons to the locus ceruleus. Now, the periaqueductal grey matter, which actually branches into the raphe magnus through other interneurons. So the raphe magnus is found between the pons and the medulla. What happens is, through a cascade of interneurons, including GABA and enkephalins, and can cause activation of serotonergic interneurons on the periaqueductal grey eventually, and the locus ceruleus through activation of interneurons, and it eventually comes to noradrenergic interneurons, and these called activation of further interneurons, which actually branch back through into the spine via the dorsolateral tract. Now, these then act to cause the release of the body's own endogenous opioids at that junction between the primary neuron and the next interneuron at the ascending pain pathway. So if we zoom in on this, this is our, primary neuron, let's say, and that's the, secondary neuron. Now, this would be our presynapse. This would be the postsynapse. And this is that innervating interneuron that's come down from the descending pathway. Now, usually what happens is it causes the release of endogenous opioids like endorphins and enkephalins, and these enkephalins, they'll actually bind to the presynapse and of this first sensory neuron. That causes presynaptic inhibition, terminating that transmission, and also binds to opioid receptors found on the postsynapse, and that's going to terminate that postsynaptic neuronal transmission. And obviously that's going to leave us with a net effect of neuronal inhibition, and then we're going to get termination of our pain signal. Now, as you can see, this means exogenous compounds or drugs which bind to opioid receptors may actually terminate pain transmission. However, it's best also to remember that further up the descending pathway, you have these other neurotransmitters involved, especially like serotonin and noradrenaline. Those which act to increase activity of these, so say for example serotonergic and noradrenergic activity, such as tricyclic antidepressants, which act to, act on serotonergic and cause serotonin and norepinephrine reuptake inhibition to increase the amount of those neurotransmitters. That will help to innervate this and activate this descending inhibitory pathway. And another example are serotonin norepinephrine reuptake inhibitors. So example of a TCA may be amitriptyline, and that of an SNRI may be, for instance, duloxetine. Now, obviously, those acting on other parts, but these are just some important ones to know. Now, this is actually going to be more effective on pain which originates due to effects on the nerves. If you cut nerve transmission, this is going to be more effective, these style of drugs, than those which don't have much effect on the nerves. So say, for instance, paracetamol, or even to some extent an NSAID like ibuprofen. So this brings us back to our first drug therapy problem. If we come back to our question, the patient likely is suffering nerve pain. So really a drug that works on the descending inhibitory pathway is best, and this explains some of the drugs placed in many of the prescribing guidelines. Say, those based on the UK prescribing algorithm, there are drugs which work on serotonin and noradrenaline, e.g. TCAs or SNRIs, or those acting in some way to terminate neurotransmission or cause some inhibition of that transmission. This is probably why paracetamol being taken by Mrs. Payne wasn't much help. And usually for diabetic painful neuropathy specifically, usually we give the SNRI, duloxetine, is specifically licensed for that, for diabetics. Now, although there is similar efficacy when compared with, say, tricyclics, it's licensed for, diabetics and nerve pain in these diabetics. Now, this is something that should be flagged up with the prescriber about potentially this not being the best use to help treat the pain, and it may not actually alleviate it. But obviously we need to bring this up with the prescriber. Now, the second drug therapy problem is that Mrs. Payne has been taking her metformin on an empty stomach. Now, metformin has been known to cause gastrointestinal upset. So examples include nausea or diarrhea or flatulence. So that's like gas, which is what's being experienced by our patient. The cause for this is, it's unknown, but many mechanisms have been proclaimed, such as an effect on serotonergic receptors, potential alteration of microbiome in the gut, or even having an effect on incretins, specifically GLP-1, which are peptidases released in response to glucose, and it has some effect there, to some believe. Now, the incidence of this side effect is reduced when taking the medication with food. So we decrease the side effect if you have it with food. Now, this is important to know, that we should tell the patient that the medication should be taken with food, because they're taking it on an empty stomach, and this is probably why they're getting the GI upset. And so if we tell them to eat it with food, hopefully that should help alleviate the problems, and we should come up with some sort of plan to help with the compliance and find is there an underlying reason why they're finding it hard to take the medication, or come with another routine that might be able to make it easier, for them to be able to comply with the medication. Now, the issue should be flagged up with the prescriber if, taking it with food doesn't help. Other options that may be tried can include, say, modified release preparation. This might help because the peak level would be lowered, but it may be important just to let the prescriber know, so it can be put in the notes anyway, as it's something that may not have been picked up, and in case there's another reason why the patient's getting gas, and we should just put our input to see, okay, has this been considered? Now, with both drug therapy problems identified, let us move on to the patient query portion of the case study. So the question reads, Mrs. Payne comes back into the pharmacy the following week telling you she has been diagnosed as anemic based on her blood levels taken by the GP and started on iron tablets, ferrous sulfate, which she got from the pharmacy next door since you were closed on the weekend. However, she has now noticed her stools have gone black. She tells you she hasn't made any changes to her diet, which is quite healthy, including eating lots of fruits and vegetables, drinking plenty of water, etc. She also goes to Tai Chi classes and started going for walks in the park every day to help with her diabetes. Mrs. Payne asks for your advice. Now, iron tablets, which are those which contain ferrous, are known to change the stool colour black. So these iron tablets can actually change the stool colour. Now, it's unlikely it's anything more sinister like bloodiness, stool, since she has no other associated symptoms like, severe epigastric pain or signs of an ulcer or anything like that. So it's best to reassure Mrs. Payne it's unlikely there's anything sinister going on, and it's just a harmless side effect of taking iron tablets. Now, that wraps up today's case study. If you found today's video helpful, please give it a thumbs up and don't forget to subscribe to the channel, making sure you hit the bell icon, of course, to keep updated on new videos.